when I talk about hypertension, it will be in the background of the International Society of Hypertension guidelines and why was it becoming necessary to have those guidelines now in globally so as that we can treat our patients in a better way. I'm going to start actually with case studies, and this is the first case study which I have. It is of a coronavirus which has wreaked an extensive damage on the liver of a 59 years old man. And you can see that what coronavirus has done is, you see, with the yellow markings that you see here, this is the extensive damage which it caused to this individual, and ultimately this patient expired. Now, when we talk about patients who have expired with COVID-19, I would also refer to a case study which actually I followed myself. And this was a patient, a very dear friend of mine, about 75 years old. He rang me up and he said that he was running his clinic and he became COVID positive. At that time, he was running temperature, didn't have any symptoms of breathlessness, and ultimately, he started developing breathlessness. After a few days, this was on Tuesday when he was COVID positive, and on Wednesday he got admitted. And Wednesday evening, I felt that he was getting a little breathless when I was talking to him on the telephone. And on Thursday, he became more breathless. And then somebody asked me from the hospital that if in case that we need to put him on a ventilator, should we do it or not? I said, no, you must put him on the ventilator. Then on Saturday morning, Dr. Saab called me and he said in Punjabi, यार मेरी तबीयत ठीक नहीं है और मैं जरा ना हुन खांसी दे विच थोड़ा जिहा खून भी आ रहा है वो डॉक्टर आएगा तो मैं तेरे नाल गल करावांगा ताकि फिर तू उन्हें गाइड कर सके कि की करना है किस तरह करना है मैं कहा बिल्कुल ठीक है डोंट वरी you must have the willpower and inshallah you will come out of it. Gradually his oxygen saturation started dropping. It became 50% and he was put on a ventilator at about 2 o'clock. And unfortunately, we lost him at about 4:30 the same day. So this is the rampage that this disease actually has on the body. And what we should actually feel about it is also that the lungs are ground zero as far as the effect of COVID-19 on the body is concerned. But it tears through the entire organ systems of the body, right from the brain to the blood vessels. And the ferocity of it is really breathtaking and very, very humbling, as in the case which I just narrated before you. Several times people who have been working in these units, they have written about their experiences, and they would tell you that they are having patients who develop seizures also. There are patients who, while they are taking a round, suddenly have a cardiac arrest and they expire. These were all patients who were COVID positive. So the story of COVID-19 positive is unraveling as to what it really does, the havoc it plays with the body. We all know that in a large majority of cases, this is asymptomatic, but when it does become symptomatic, in those 15% and becomes critical in those 5%, it is terrible. Now, this is the picture of a patient who actually was admitted in the Mount Sinai Hospital in US and has survived this COVID-19. He's come out of the ventilator now. But what will happen ultimately to this patient? And if we look at the survivor's burden, it is really, it will be something, the sequelae, you see, when the patient develops pneumonia, there'll be scarring on the lungs. There will be an effect upon his psyche. There will be an effect upon his brain. He has been socially isolated from his family, from his friends, And that ICU syndrome, which occurs in these individuals with lack of physical rehabilitation, which normally we carry on in our patients in the intensive care unit, that is lacking now because you cannot have more people attending to these patients. So they will come out of this, out of this experience, but they will carry this sequelae for probably weeks and months or years even. And I think the story about COVID-19, the survivors and those who have died in it is far from over. When we look at what it can do to the brain as well, you will see here, this is another 58-year-old woman with COVID-19. She developed encephalitis and with tissue damage here. You can see it is shown by these arrows. So COVID actually affects every system in the body. This is another patient who was admitted, had this the ST segment elevations as well. There were tachycardia, which you can see here. A bedside echo showed a right ventricular enlargement, which has occurred in this patient. And this has been because they developed the ARDS. As a result of that, there's a load on the heart, the right ventricle enlarges, and this patient also expired. Another patient who was admitted and a bedside echo, COVID positive, you can see that the right ventricle was not enlarged. But just on the third day, look at the dilatation in the right ventricle. You will see here also in the first patient, the left ventricle is small. Here as well, the left ventricle is small and the right ventricle is dilated, and both these patients expired. So it affects every system in the body. It affects the heart, it affects the gut, it affects the brain, it affects the kidney, because the AC2 receptors are everywhere. So when we talk about SARS slide, and now the number of patients with COVID-19 at this moment in time, the world over, are about 5 million. And we all know some of the basic facts about it, that it has reached a pandemic level since March 2020. It not only causes viral pneumonia, but has major implications for the cardiovascular system, and I'll show that to you. The cardiovascular comorbidities are common in patients with COVID-19 infection, and that is what we are seeing here as well, which I discussed with you about the case study of my friend. Presence of cardiovascular disease is associated with increased mortality in COVID-19 infections, and it correlates with the increasing age, and I'll show you a graph for that. Now, this is just to show you the incidence starting from Wuhan here and going all the way to Europe and then to America. It's all over the world now, and the epicenter now has shifted to Latin American countries, especially in Brazil, where there's an increasing incidence of COVID-19, even in comparison to the United States and Europe. Now, when we look at, before the presentation, I was talking to Professor Bilal Mohyuddin, and he used the word war. And then he said that basically it is with every disease. When we look at this, we see that the invaders' impact, SARS-CoV-2 rests here. It has a predilection for the nasal area, where you have the maximum AC2 receptors. And it lands in the lungs from here and can do deep damage. But the virus or the body's response to it can injure many other organs. And that is what is the cytokine storm that we talk about. And scientists are just beginning to probe the scope and the nature of that harm. The disease is so new that I think we still have to grasp the impact of it on the body. It affects the lungs. Here is where the war is actually ravaging. And it results into the formation of this pus here in the alveoli, which then prevents the oxygenation of the blood, which is passing nearby in the capillaries. It affects the heart and the blood vessels, the brain, as we talked about, seizures, confusion, strokes. And I have, even when I talk with some of these patients who are positive and are hospitalized, they do have headaches also. They get conjunctivitis, they have nasal problems. Then it also affects the liver. The liver enzymes go up. It can actually affect the kidneys per se because there are the ACE2 receptors present there also. Plus, because of the involvement of the lungs and the heart, there is a effect on the kidneys. So not only are we going to be overwhelmed by the ventilators, but what I feel is even the dialysis machines are going to become few because as the patients progress into that condition, they might be needing it. But I'm not sure that how many of our patients are being put on ventilators, and if they are being put on ventilators, is it being done properly? Because now there are special modes for that you have to keep the patient with COVID on this particular mode. And then if you have the dialysis machines, you have to restrict it for those who are COVID positive. And that is going to actually have an enormous economic impact on our hospitals. So when we look at the cardiovascular manifestations, then we see that it is associated with myocardial damage and cardiac arrhythmias. And I showed that to you in that ECG where there was sinus tachycardia with bundle branch block with ST segment elevation. Now in the severe infection, you can get cardiac arrhythmias and patients will die because of cardiac arrest developing as a result of ventricular tachycardias and ventricular fibrillation. Then we have to monitor the cardiac toxicity of the antiviral drugs that we are giving into these patients. Also, the COVID-19 infection seems to have a comparable cardiac manifestation. Next to acute complications, COVID-19 infection may also be linked with an elevated long-term CV risk. Now, this is what I was talking to you about, the survivor's burden, which is going to be there in these patients. I think by now, for the last 2 months, we've been hearing these webinars, and we know actually what really happens. The virus attaches itself to the ACE2 receptor here, enters the cell plasma, replicates itself. Actually, it acts like a terrorist here and causes havoc inside the cells, replicates multiple times, and this then increases the infection that there is. It was being said that ACET, it is actually true, which is expressed in the lungs, heart, and vessels. And the renin-angiotensin system is important in the pathophysiology. Now, the thing is that what the ACE inhibitors and the ARBs are doing is that they basically upregulate the ACE2 receptors, and this has been shown only experimentally. The ACE2 receptors basically, they are protective for the lungs. And if SARS occupies these receptors, that protective element is gone. However, if the ACE inhibitors and the ARBs are withdrawn, you will take back the beneficial effects which these drugs have on our patients, both with hypertension and ischemic heart disease, coronary artery disease, heart failure, and they will then probably become far more serious. And there is no evidence that stopping these drugs will reduce that infection. However, there is some evidence that starting the ARBs in these patients or putting them on ARBs may have some beneficial effect, as has been seen in some of the experimental studies. But these studies have not been actually demonstrated to have the same effect in humans. The studies are going on with losartan and with irbesartan. How did these patients who have cardiovascular condition in COVID-19, how do they present themselves? With chest pain, with dyspnea, cough, respiratory distress, cardiogenic shock, out of hospital cardiac arrest, pulseless electrical activity, sudden cardiac death, tachyarrhythmias, bradyarrhythmias, and hospitalization for pneumonia and time course of increased subsequent risk of cardiovascular death. So this is how these patients who have cardiovascular conditions and contract COVID, how they make the presentation. Now, how are we going to diagnose the cardiovascular conditions? Obviously, by the use of an electrocardiogram, biomarkers, non-invasive imaging, and differential diagnosis. The biomarkers in these patients, like troponin I, they are, if they are increased remarkably, then they have an adverse prognosis. These patients with high troponin I levels, they usually have a worse prognosis in comparison to those who do not have these levels raised. Now, coronavirus 2019, actually they pose a large number of these patients, they develop arterial and venous thrombosis. It predisposes, COVID-19 actually is predisposed because of the existing cardiovascular disease, and these patients have a thrombotic lesion both in the arteries and the veins. The initial series suggests the common occurrence of venous thromboembolic disease in patients with severe COVID-19. The optimal preventive strategy warrants for a further investigation. We also have to be very careful about the drug-to-drug interaction between these antiplatelet drugs and the anticoagulants, which have to be used in these patients with COVID-19. And the available technology should be used optimally to care for patients without COVID-19 who have thrombotic disease during the pandemic. Now, when we see what really happens here is that in the outbreak of a respiratory infection, what it can do is that the primary target, if it is the heart, as a result of the AC2 receptors here, patients will develop hypotension, tachycardia, bradycardia, arrhythmia, and sudden cardiac death. And there's a surge of pro-inflammatory cytokine. Actually, it is an exaggerated immune response to the invaders that you get a cytokine storm, and that becomes harmful for the body as also. Then the interaction with the cardiovascular system, where the cardiovascular disease is already prevalent in an infected cohort and may become, these patients will become rapidly unstable. And the patient, the doctor I mentioned earlier on, basically was hypertensive and had ischemic heart disease, but his ischemic heart disease was stable. But despite that, when he became infected, he became rapidly unstable. And there's an increased chances of having the problems with them. The cardiac reserve falls down and the metabolic demand, and this results in a significant secondary comorbidity. This is once again the same cartoon, which will show to you as to how the SARS-CoV-2 attaches itself to the ACE2 receptors. And because of the different mechanisms involved, these are the targets now which are being studied so as to be able to control this infection. What happens to the cardiovascular system? Let's go through this diagrammatic illustration of it. It affects the cells in the lungs and causes an inflammation here, resulting in pneumonias. Then the viral invasion can affect directly the muscle of the heart, resulting in fulminant myocarditis and myocarditis, causing myocardial dysfunction and damage, resulting in arrhythmias, resulting in heart failure, the cytokine storm, destabilizing the plaque and resulting into a rupture of the plaque, causing an acute coronary syndrome. It can also have an effect upon, it causes endothelial dysfunction, results in microvascular disease and microvascular dysfunction. So the entire spectrum is what really happens to these patients with the COVID-19 infection as they invade the body and they affect the lungs and the heart and also the brain and the kidneys, as I showed to you. They also affect the gut. And sometimes the first manifestation of COVID-19 can be nausea, vomiting, and diarrhea. What has also been seen is that even though it can, it was considered that maybe the virus is excreted via the feces, but it is not the whole virus which is excreted. It is the RNA or some fragments of it, and therefore probably the oral fecal route is not the route for transmission of this condition. Then, uh, can we get this thing away, the C waiting room, please, Vahid? Now, when we look at what really happens is how the disease in the first few days you have from day 1 to 14, the disease type, you have all these symptoms here, which I had enumerated before also. And then the disease becomes severe at this point in time. And if you remember that patient who had fever, who had probably mild cough, he had fatigue, and there was no nasal congestion, there was no sore throat, but he had myalgia. And I think this was continuing there for about a week or so. At this point, he developed severe disease when he started having shortness of breath and dyspnea. And his oxygen saturation without the oxygen was less than 94%. In fact, it was less than 90%. And then gradually dropped down even further. And after that, towards 7 days plus minus, after that, you get a rapid deterioration when there is a sepsis, a multi-organ failure, and that actually becomes critical for these patients, and most of these patients then do not survive. Now, this is a CT scan of a patient who has COVID-19 infection, and you can see the ground glass appearance at this level where you see the infiltration as a result of the COVID-19 infection. What happens in the heart, you can see that this is an echo of the left ventricle, which is enlarged, and then you see it's by and large globally hypokinetic. The right ventricle, in this case, appears to be normal, but the LV definitely is enlarged and with a very reduced ejection fraction. This is the polar map which shows the same thing. Now, what are really the risk factors which can result in a person getting COVID-19? Or who are those patients who are basically vulnerable to it? And you have the older age, more than 65 years, chronic lung disease, cardiovascular disease, diabetes, obesity, immunocompromised, end-stage renal disease, and liver disease. When we look at cardiovascular disease, diabetes, obesity, vascular disease as such, and so this also makes them more vulnerable to developing this infection. And when we look at the hospitalization with the pre-existing conditions, which has been written or published in several papers, you will see that any underlying condition increases the chances of their hospitalization. Hypertension more increases the chances of hospitalization. Obesity, diabetes, lesser, cardiovascular, but by and large, you will find that hypertension in these patients is probably one of the main conditions which makes them vulnerable to contracting COVID-19. And probably we'll talk about it, why it is so, or is it really a fact, or is it confounded by age? And when we look at the survival in these patients also, you will find that as the age advances in these patients, the chances of survival, if they develop a critical disease, are much less as compared to the younger patients. The other conditions also affect it, but by and large, it is the age which makes them more vulnerable. And that is what was seen, I think, in Italy also, where in the nursing homes, it was the advanced age, actually, which was resulting in severe COVID-19 infection, and the patients expired more in that area. Also, when we look at the reports from China, it was noted that hypertension was one of the most common comorbidities. And now these patients who are self-isolated hypertensive patients, it is important that they should be telemonitored, they should keep on taking their medicines, their blood pressure should be under control. And uncontrolled blood pressure actually results in contracting a more severe COVID-19 infection as compared to a controlled blood pressure. And those patients who are hospitalized are hypertensive. In these patients, there is no reason to stop the medicines, even if they are taking the ACE inhibitors or ARBs, unless and until they develop hypotension. So just to recapitulate what we have learned up till now, cardiovascular patients are at an increased risk of severe COVID-19 and its complications. Intensive preventive measures should be followed in this group in accordance with the WHO and CDC guidelines. This should include wider use of telemedicine tools in day-to-day monitoring. We should be in contact with our patients so that we can advise them. And I tell you frankly, for the last 1.5 to 2 months, anybody who calls me and I find out that it is a patient who's calling me, I always respond to him and try to explain to him what he should do in these stressful conditions. In fact, not just stressful, but cataclysmic conditions. The heterogeneity of responses between the individual patients indicates that it is unlikely that it can be considered as a single disease phenotype. The host characteristics promote more or less severe progression of the disease. The most common cardiac complications, which we earlier on talked about, are arrhythmias, atrial fibrillation, ventricular tachycardias, ventricular fibrillation, cardiac injury when they have a raised troponin I and CK, fulminant myocarditis, and heart failure, which I showed to you in that circle, which I demonstrated on that slide. The cardiac complications often appear 15 days after the initiation of fever. The symptoms, which are the initial ones when these patients develop COVID-19. Evaluation of cardiac damage, particularly of the troponin levels, immediately after hospitalization for COVID-19, as well as monitoring during the hospital stay, may help in identifying a subset of patients which predict the progression of COVID-19 complications. Some of the medicines which are used in COVID-19 treatment may contribute to cardiac toxicity, while their effectiveness in treating COVID-19 is unconfirmed. And that is what hydroxychloroquine and chloroquine comes under. Because we do not know whether it is really useful or not. And if it is used in combination with Isomax, the QT interval becomes so prolonged, these patients can develop sudden cardiac arrest. And this has been seen in patients in Western countries. So when we talk about the cardiovascular morbidities, comorbidities, as far as hypertension is concerned, it is one of the main comorbidity which is seen to be associated with COVID-19, but it is not clear if hypertension is an independent risk factor or there is an age, the element of age which is also accompanied with it. So there may be a confounder of age with hypertension. So we are not clear whether it is principally it is just hypertension or it is that age which I showed to you. As the age advances, the chances of COVID-19 being contracted are more, and that then the infection being more severe is far more in these patients. There's a clear evidence that ACE or ARBs are associated, no evidence that ACE or ARBs are associated with worse prognosis, and patients should not discontinue the use of these medications. It is extremely important. And based on experimental evidence, it may be possible that ARBs and maybe ACE inhibitors might have a potentially protective influence in the setting of COVID-19. COVID-19 may lead to plaque instability, which I showed to you because of the cytokine storm, which is a common cause of death in these patients. However, the evidence of effectiveness of primary PCI for type 2 MI during acute viral disease is limited. We do not have the experience for that because the number of cases reporting to the hospitals have reduced quite a bit. the ACE2, which was never considered before this COVID-19, it has adopted, or it has been given a center stage in the understanding and the potential in combating COVID-19. It is now being named as the Cinderella of cardiovascular medicine. So to summarize the key points on ACE2 receptor allows the virus to enter into the cells. The ACE2 in full length is membrane-bound enzyme. The shorter soluble form circulates in low concentration. ACE inhibitors do not inhibit ACE2, period. ARBs have been suggested to upregulate ACE2 and differs per ARB and per organ. There's no data that ACE or ARB facilitate COVID-19 virus entry by increased ACE2 expression. Animal data supports potential pulmonary and cardiovascular protective effect of elevated ACE2 expression. So if the ACE2 receptors are upregulated, because they are protective for the lungs and for the cardiovascular system, the animal data actually supports that the increased the upregulation of ACE2 receptors actually can be beneficial for the patients. And the patient should not discontinue ACE inhibitors or ARBs because COVID-19 infection based on current available evidence. What happens after a few days? We don't know, because more and more studies are being carried out, and probably we'll have some data. Even now, when these papers are being accepted for publication, none of them are being peer reviewed. And now, initially, if there were hardly any 8 to 10 papers in week 1, today there are over 150 papers which are being published on COVID-19 and its effect upon the human body. Now, I'm going to talk to you about hypertension. We have discussed what COVID-19 is, how it affects the entire body, in fact, ravages the entire system, destroys most of the organs of the body, and the cardiovascular system, cardiovascular disease makes the patient more vulnerable to it. Age is the most important factor in COVID-19 infection becoming severe. Hypertension also. However, whether hypertension is associated with advancing age, which makes these patients more vulnerable, has to be further studied by taking out the confounder of age in it. And I'm now going to discuss with you the new guidelines which have been released by the International Society of Hypertension. And the reason for those guidelines to come out is because if you look at the European Society of Hypertension guidelines, and if you look at the ACC guidelines, these are guidelines which have been developed in advanced countries where the incidence of hypertension is not as much as in our countries. Then the resources in our countries are far less than in the West. Therefore, we have to have more practical guidelines, more pragmatic guidelines, more resource-driven guidelines in our part of the world to be able to reduce the global burden of a raised blood pressure, which is affecting our part of the world immensely. In the entire world, there are over 1 billion patients who are hypertensive, and it results in about over 10 million deaths per year. And despite all this, the awareness, treatment, and control rates of hypertension are much less. In Pakistan, several years back, when we used to make our presentations, we said that over the age of 18, about 18 to 20%. After the age of 40, 1/3 are hypertensive. And in 50s and 60s, the chances are that 90% of the people will become hypertensive in Pakistan. Now the data is showing from, which was released from Karachi, nearly 41% of patients in Pakistan are hypertensive. That shows us the enormousness of the problem and the importance that we should be able to treat blood pressure as best as we can and that our patients should adhere to it. They should comply with the medicines that we are giving to them, because unless they take the medicine, their blood pressure will not come down. The drug will only have its effect if it is taken. So the ISH guidelines actually divided the treatment in two modes, the essential part and the optimal part. The optimal is, according to the guidelines, you do the best that you can for these patients. You give them according to the guidelines, which I'll show to you. The essential is in a resource-driven society where, or in those places, if patients come to us, they're with limited resources, then what we need to do is that we recognize that and also try to put them on medicine which will bring down their blood pressure as much as possible to prevent morbidity and mortality. So that is why it is practical to think about two forms of approach: the optimal approach, which is the best approach, and the essential, which is the bare necessary, which should be adopted in these patients. What they have really done is also that there's not much of a change as far as the classification is concerned. The normal blood pressure is less than 130 by 85, and at the level at which you label a person hypertensive is 140 by 90. Then you have the category of high normal, which probably you would try to treat these patients with non-pharmacological methods of treatment. And then you have two grades, the grade 1 hypertensives and the grade 2 hypertensives, where you have the blood pressure, as you can see on the screen. Here you have in grade 1 hypertension, you will have 140 to 159 systolic and 90 to 99. And in grade 2, more than 160 systolic and more than 100 diastolic. How are you going to monitor these patients? Office blood pressure is going to be the most important one. And then you have ambulatory blood pressure and home blood pressure measurement where it is possible. Optimally, yes, this is what you should be doing. But if it is not possible for you to have ambulatory blood pressure monitoring or home-based blood pressure monitoring because of the constraints of finances, then just rely on blood pressure. That would be the essential part of it. The optimal obviously has all the, and these are the different levels that you have for the classification of normal blood pressure when you're using the other modes as well. Now, how would you measure this blood pressure? Very important that what we always suggest is that the patient should be seated comfortably with the feet secure on the ground, not dangling, the back supported, the arms supported, and the blood pressure apparatus at the level of the heart. And you will find that you will be able to have a correct reading. Just briefly, what I'm sure each one of you is doing this also, but what I usually do is that when the patient comes and sits with me, it is important that they should not have taken tea, caffeine, or they shouldn't have smoked a cigarette 15 minutes to half an hour before that. They should have emptied their bladder. That is also very important. And when they're seated here and you're taking the blood pressure, it is important that you should not talk to the patient and the patient should not talk to you. That also elevates the blood pressure. So it is best that you keep the room as quiet as possible and then make a recording. You take a recording on one arm, then on the other side, and once again come back to the first arm. So what you discard the first reading and take the average of 2. Some of the doctors feel that this may take a long time, but I think it hardly takes 2 to 3 minutes to be able to take these readings a minute apart, or you can actually wait for more time so that the blood pressure settles down also. Then another important point as far as monitoring or measuring the blood pressure is be careful regards postural hypertension, which occurs in elderly patients. So always take the blood pressure in a standing position also to eliminate the chances of postural hypotension when you're giving medicines to these patients. I remember when we used to be on the rounds in the ward, and my teacher and mentor, Dr. Shaukat Malik, would always make sure that the patient stands up, and then he himself would put the shoes or the slippers next to the patient so that he can put he should not put the feet on bare feet on the ground. That also raises the blood pressure, especially in the cold weather. So I think these small considerations, if they are kept in mind, you will be able to make the correct diagnosis of blood pressure. Because it is important to make the correct diagnosis, because the patient is going to be labeled as hypertensive or not hypertensive for the rest of his life. And if he's hypertensive for the rest of his life, he will be taking those medicines for the rest of his or her natural life, and will have all the side effects. So it's extremely important to make the correct diagnosis right from the beginning and then start your treatment in these patients. Same applies for home and ambulatory blood pressure. When it is for, if you're asking the patients to record the blood pressure at home, it is preferable to have it for 3 to 7 days in the morning before drug intake and in the evening. And then you can, he or she can bring the record to you, and you can then identify the readings there and see what has to be done. Then you can interpret it. Similarly, with the 24-hour ambulatory blood pressure, you will be able to see if they are dippers or non-dippers, and what is the trend of the blood pressure, because there is going to be a variation definitely, and it is a variation with every one of us. Extremely important that we have a proper medical history, and in all patients, more so in patients with the cardiac problems, where you will be able to find out if they have any risk factors, if there is an assessment of the overall cardiovascular risk, that should be done, the symptoms or signs of hypertension or any other coexistent illnesses, and then the symptoms suggestive of secondary hypertension, which can occur in 5 to 10% of the patients, and that should be excluded. The physical examination, one must always look for enlarged kidneys, a thyroid, increased body mass index and waist circumference. Lab investigations, basically you should have an electrocardiogram, sodium, potassium, serum creatinine. There's no difficulty in doing an estimated GFR. There are these methods available on the internet. You just Google them, you put in the data, you'll get the estimated GFR. You don't have to ask the lab to do it for you. And when we do an ECG, we look for the detection of any atrial enlargement, any atrial fibrillation in our patients, left ventricular hypertrophy, and any evidence of ischemic heart disease. We can have some special imaging techniques in our patients. Echocardiography is important, left ventricular to see LVH, systolic and diastolic dysfunction. Diastolic dysfunction, I found, is very common as the age advances. Any atrial dilatation, aortic coarctation, so that you can treat the hypertension in these patients. Carotid ultrasound, all you need to do is put a transducer on the carotid vessels here, and you can see the intima-medial thickness. This will give you an idea that whether atherosclerosis has already taken place or not. You might be able to see some plaques also, soft or hard, in these patients. You do an ankle brachial index, it should be done. That also gives you an idea about peripheral arterial disease, which is common in these patients. Do aldosterone-renin ratio, urinary albumin-creatinine ratio, serum uric acid, and the liver function test. So these are the basic tests at baseline that should be done. We need to assess the cardiovascular risk factors, and we have a system for that here. So whether there are 1 or 2 risk factors, more than 3 risk factors, because if you have a hypertension-mediated organ damage or CKD, grade 3, diabetes, cardiovascular disease, it makes your patient in that high-risk category where treatment becomes mandatory. So to decide whether this patient has a high normal blood pressure with a low risk, then these patients will probably be managed on non-pharmacological treatment. Those who have some risk factors in grade 1, in grade 2, then according to the patient you individualize the treatment in these patients as far as the treatment of hypertension is concerned. So I've mentioned the hypertension-mediated organ damage. The following assessments, essentially, suppose you have a resource, if you do not have the resources to have the test done, then basically you can just get the serum creatinine, a dipstick to see the protein, urea, and 12-lead electrocardiogram. In optimal, you will do all the evaluation that I've mentioned to be able to find out if the patient has hypertension-mediated organ damage. What are those conditions which can actually exacerbate hypertension? We have the drugs like the non-steroidal, anti-inflammatory, contraceptive pills, antidepressants, very common these days, acetaminophen, other medications, and then people are also taking off the counter herbal and other substances. They also raise the blood pressure, and one should be cognizant of all these things. Basically, as the age advances, not only are there many comorbid conditions, but there is a lot of polypharmacy which is going on. And you have to keep that in mind whenever you are treating your patients with hypertension. You should ask your patients what other drugs they are taking. And invariably, you will find that they are on some non-steroidal anti-inflammatory because of their joint pains, or they are taking some antidepressants. All these conditions must be kept in mind when you are treating your patients. A proper medical history, a proper examination, and the basic tests, and then any history related to other conditions and other medicines which are there. So when we differentiate between the essential and the optimal, screen all patients with hypertension and those at risk for hypertension for substances that may increase blood pressure, or they may interfere with the blood pressure lowering effect of antihypertensive medication. When appropriate, consider reducing or eliminating substances that raise blood pressure. Invariably, I usually dissuade the patients from taking these non-steroidal anti-inflammatories. Even if you give them some ointments to apply, they are also absorbed. If these substances are required or preferred, then treat blood pressure to target regardless on possible antihypertensive therapies that target mechanisms underlying the raised blood pressure induced by these substances. What about the treatment of hypertension, which is extremely important? Lifestyle modification, pharmacological treatment, and adherence to antihypertensive treatment. First and foremost, we must talk to our patients, advise them about lifestyle modification, and persist that they should adopt a change in their lifestyle. On every visit, re-emphasize pharmacological treatment, I will discuss with you, and make sure that the patients adhere to their treatment. Now, when we talk about this lifestyle modification, salt reduction, it is not enough to say, कि जी आप अपना नमक कम कर ले. I think it is best to describe to them how much. Now it is recommended 2 grams and less. A healthy diet. The water is the best thing that you can have. No fizzy drinks, no Coca-Cola, no McDonaldization. This is bad for your heart. This is bad for your blood pressure. Moderation of alcohol consumption. My advice is don't take alcohol at all. In our society, I think this is it is also important to talk to them, because there are people who take alcohol. One should always advise them about it, that they should abstain from it. This particular lifestyle modification is actually mentioned for the West when they talk about moderation, and they actually define the drinks that are taken, how many for the women and how many for the men. At least in our society, we have the chance or the a reason for asking our patients not to indulge in alcohol intake. Then weight reduction is extremely important. my advice always is that what was your weight at the age of 24, 25, and what was your waist at that time? You go back to that weight. Reduce your waist as much as possible. The waist circumference should be such that you should look smart and active. And I think that if that look comes in, it gives you more confidence. Then smoking under all circumstances should be forbidden. In any form, gutka, shisha, cigarette, cigar, anything. I remember in the younger days, people used to sit on the television screen with a cigarette dangling from their fingers or from their lips. But now at least we don't have that. And it is my earnest request to the government also that they should increase the taxation on these cigarettes so that people do not, at least a majority of them are unable to afford it. And that will bring down the incidence of smoking. And if that comes down, you will see the graph of coronary artery disease, of smoking come down. Smoking actually not only increases the cardiovascular diseases, the pulmonary diseases, but it also affects the kidneys because it causes dysfunction of the endothelium. And it is not just the dysfunction is occurring, it is the entire system. And I remember a patient admitted in Federal Government Institute in Islamabad who had and started having gangrene, first of one leg, then of the other, amputated. And unfortunately, he still picked up. He had one of his hands had to be cut off. It was terrible to see the way he was going, but still he would not give it up. It's a kind of an addiction. Okay, so we have the essential and the optimal treatment strategies. When we have the essential, the target blood pressure reduction is at least 20 by 10 millimeters, ideally to less than 140 by 90. And in the optimal, if a person is less than 65 years, the blood pressure target has to be less than 130 by 80. And if tolerated, less than that, but never less than below 120/70. If over 65 years, then the target is less than 140 by 90, if tolerated, but consider an individualized blood pressure target in the context of frailty, independence, and likely tolerability of treatment. So you actually have to see how frail the patient is. If he is very frail, then you have to bring it down to a level which he can tolerate. First, we'll concentrate onto this side of the treatment, the optimal one, where the step one, once you have diagnosed the patient, ideally, we will be starting a patient on a single pill combination therapy and go with a dual low dose combination. Step one, it should be an ACE or R. It is not anymore ACE if contraindicated ARB. It is straight away ACE or R. You can actually start with an R and a calcium channel blocker. Now, with some caveats here, which are mentioned here at the bottom, consider monotherapy in low risk, grade 1 hypertension, or in very old, over 80 years, or frailer patients. Consider ACE or R with a diuretic in post-stroke, very elderly, and incipient heart failure or calcium channel blocker intolerance. And consider ACE or R with a calcium channel blocker or calcium channel blocker and a diuretic in certain ethnic groups. Caution with spironolactone because of potassium. And here, when we start with a low dose combination, if the blood pressure is not controlled, go to a full dose combination of both the drugs, A and A plus C. And if still the blood pressure is uncontrolled, you then add a diuretic to it. And the diuretic should be thiazide-like. And in step 4, when the patients are resistant, then you're going to add spironolactone or eplerenone or any other drug in these patients. And this is the combination that will be used. Now, when you come to the left-hand side in the essential group, use whatever drugs are available with as many of the ideal characteristics. You see, you don't have to then concentrate. You can even have a free combination if single pill combinations are not available or are unaffordable. And you can use thiazide diuretics if thiazide-like diuretics are not available. And if the calcium channel blockers like dihydropyridines are, if these are not available or are not tolerated by the patient, then obviously you have the choice for diltiazem or verapamil. Now, when we're talking about the beta blockers, we consider them at any step when there is a specific indication for their use. For example, in patients with heart failure, angina, post-myocardial infarction, atrial fibrillation, or younger women, or planning a pregnancy. So this is the mainstay of treatment, the optimal as it is given. It's very simple. Low dose, dual combination, step it up, add a diuretic, not controlled, add spironolactone. Essential, use whatever drugs you can to bring the blood pressure down to by 20 to 10 millimeters, 20 systolic and 10 diastolic. Now, why was there a need, or is there a difference between the International Society of Hypertension guidelines and the European guidelines? Actually, the International Society of Hypertension guidelines are more global and they are more applicable to our population. And here, for example, ESC focuses on optimal care. Here, the focus is both on optimal when possible and essential as a minimum. Then you have the blood pressure classification. You need to bring down the blood pressure to less than 140 by 90. And I advocate that it should be a range. Like you can have a range from 120 to 130, 35, 130, because it is like you are playing cricket and you are dropping the ball on good length. That is what you need to do. And when you're controlling the blood pressure in your patients, you need to keep it at the good length, and so that you're not hit out. Cardiovascular risk treatment, this is what you're going to see. You will calculate these scores. In the European Society, they have specific scores. Here you can use any assessment tool. The drug treatment we've just talked about grade 2 hypertension, grade 1 and high risk, grade 1 and low risk. And then you have the drug treatment and lifestyle. It should always be like that. And this is the same here with the ISH also. In essential, you focus more on grade 2 and high risk grade 1 if resources limited. So you are able to treat every patient. There's not much of a difference between lifestyle interventions in the patient, in the recommendation from ESC as compared to the ISH. The only difference is that reduce stress in your patients and avoid air pollution as far as the non-pharmacological methods are concerned. And adherence to therapy is extremely important because and consider the following strategies to improve the medication adherence. Number one, you will have reducing polypharmacy. Once a day dosing is much better. Providing adherence feedback to patients, home blood pressure monitoring. You can teach them to do that. The apparatus that they use should be standardized. Reminder packaging of medications. I think the best thing is to put them in a pill box so that you know exactly what you are doing. Empowerment-based counseling for self-management. Yes, we need to make the patients proactive so that they are empowered to be able to self-manage themselves. And the electronic adherence aids such as mobile phones, or you can send them messages, you can have a WhatsApp group, send them messages about their blood pressure control. That is important. How about hypertensive emergencies? These are the various steps that you use. I won't go into the details of it, but you need to keep in mind labetalol, nicardipine that you use in these patients, nitroprusside, esmolol, all these drugs can be used. And accordingly, you have to actually keep in mind in whether the patient has a hypertensive encephalopathy, acute ischemic stroke, acute coronary event. All these conditions should be kept in mind when you are treating your patients with this. So home telemonitoring is extremely important. It is beneficial for the patients also and benefits for the health professionals. And at least in the COVID-19 era, and I hope in the post-COVID-19 era also, we'll be able to continue with this and learn from Dr. Bilal as far as the Zoom monitoring and Zoom coming and going into Zoom is concerned. Unfortunately, because of the pandemic and the crisis that we have, we could not actually organize any function on the World Hypertension Day. It is being done on the webinars, and I'll take this opportunity to spread the message that we all should spread this message to our patients and to the general public, howsoever we can do, that they should measure their blood pressure, control it, and this will enable them to live longer. So this brings me to the end of my presentation of COVID-19, of the cardiovascular risk factors or the vulnerability that you have in your patients who contract COVID-19, and how we can treat them pragmatically with the International Society guideline, which to my mind is more nearer to our way of treating as compared to the West, because our resources are limited. We should not put an additional burden on our patients. We should prescribe those medicines which are affordable to them and cost effective so that they can reduce their morbidity. We can reduce their morbidity and their mortality, which will be ideal situations. We should actually create an awareness about hypertension, treat it effectively, and advocate as much as we can for non-pharmacological treatment in these patients with hypertension. I thank you all for your very patient listening.